Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your guide through our dermatology series. Today we're diving into atopic dermatitis, a condition you'll frequently encounter in primary care. From its hallmark itchy inflamed skin to practical management strategies, we'll cover the essentials you need for PANCE prep and real-world practice. Let's get started. Starting off with some basic pathophysiology, atopic dermatitis is a chronic inflammatory skin condition. It's driven by multiple mechanisms including epidermal barrier dysfunction, genetic factors, immune dysregulation, altered skin microbiome, and environmental triggers. Who does atopic dermatitis affect? It can affect anyone, really, but it's most common in children and usually begins before age 5. It commonly coexists with asthma and allergic rhinitis in what is called the atopic triad. The strongest risk factor for atopic dermatitis is family history of atopy. If a parent has history of atopic diseases, the child has a higher likelihood of developing atopic dermatitis. Next, let's talk about the clinical presentation. Acute atopic dermatitis presents with erythematous papules and vesicles with exudation and crusting, while subacute and chronic atopic dermatitis is characterized by dry, scaly, or excoriated papules or skin thickening from chronic scratching. This thickened skin with accentuated skin lines is called lichenification. As far as distribution, in infants and young children, it often presents on the face and extensor surfaces. However, in older children, adolescents, and adults, the flexural areas like the antecubital and popliteal fossa are most commonly affected. Diagnosing atopic dermatitis is clinical. It's based on history, physical exam, and associated clinical findings. Key criteria include pruritus, eczematous dermatitis with typical morphology, and a chronic or relapsing history. The management hinges on 3 pillars: restoring the skin barrier, treating inflammation, and eliminating exacerbating factors. Number 1. In regard to barrier repair, it is important to maintain skin hydration with frequent application of emollients. Thick emollients are most effective and can be applied at least 2 times per day. Next is treatment of the inflammation. Topical corticosteroids are the first-line treatment. The choice of potency is based on the patient's age, body area involved, and degree of skin inflammation. And thirdly is avoid or eliminate exacerbating factors, such as excessive bathing or washing without subsequent moisturization, exposure to cold or low humidity environments, overheating and sweating, or exposure to solvents and harsh detergents. Now, before we move on to the practice questions, here are some pearls to keep in mind. Number 1. Scratching perpetuates the itch-scratch cycle. Breaking the cycle is key to management. And number 2. Applying emollients immediately after bathing or hand washing, known as the soak and seal method, dramatically improves skin hydration. All right, let's practice some clinical questions. Question 1. A 7-year-old boy presents with a 2-month history of an itchy rash on the inside of his elbows and behind his knees. His mother reports a family history of asthma and hay fever. The child has no fever or systemic symptoms. Examination reveals ill-defined, hyperpigmented, and lichenified plaques with excoriations. No crusting or oozing is seen. What is the next best step in management? Is it A, oral corticosteroids, B, high-potency topical corticosteroids, C, low-potency topical corticosteroids with emollient therapy, or D, skin biopsy? I'll give you a couple of seconds. If you chose C, low-potency topical corticosteroids with emollient therapy, You are correct. This is a classic presentation of atopic dermatitis. Low-potency corticosteroids are appropriate for use in flexural areas, combined with emollients to restore the skin barrier. Question 2. A 28-year-old woman presents with a 2-month history of a dry and itchy rash to her elbows. She denies any systemic symptoms but mentions that her mother has asthma and seasonal allergies. She recently moved to a colder climate, which has made her symptoms worse. She remembers having rashes as a child, but does not remember a specific diagnosis. Examination reveals hyperpigmented, excoriated plaques with lichenification to the antecubital foci. No signs of infection are noted. What is the most likely diagnosis? Is it A. Psoriasis, B. Atopic dermatitis, C. Contact dermatitis, or D. Seborrheic dermatitis? If you chose B. Atopic dermatitis, you are correct. The patient's mom's history of asthma and allergies, as well as patient's clinical presentation and exacerbation in a cold climate, are consistent with atopic dermatitis. Psoriasis typically presents with well-demarcated plaques with silvery scales. Contact dermatitis is often localized to areas of irritant exposure. And seborrheic dermatitis typically involves seborrheic areas like the scalp and face. Great job! Thank you for joining us for today's episode on atopic dermatitis. Remember, as primary care PAs, your role in educating patients and providing effective first-line treatments is invaluable. Be sure to subscribe and turn on notifications so you don't miss our next episode in the dermatology series. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.